This is happening actually because of the war, and we have several victims. Sport injury is not that much common, but it can happen, especially with contact sport. This is, I share with you, this is one of the patient with gunshot injury. You can see the bullet here in this area is already passed through the neck from the front and passed through the cord, and then it's stopped in this area. The MRI was so much obvious, although it doesn't do a lot of damage to the stability of the spine, but it's significant catastrophic effect to the spinal cord itself. And there is a published by Dr. Khalaf al-Mutairi, one paper published by Dr. Khalaf al-Mutairi, Allah yarhamu, which is showing the quality of life in male with a spinal cord injury in Saudi Arabia. That was published 2004. And it showed that to differentiate between the neurological level of spinal cord injury in the Saudi Arabia population. And they reported that 43% or 45% it is in cervical injury, as I mentioned a while ago, and 40% in thoracic region, and 3.5 only in lumbar region. And in our hospital, Prince Sultan Military Hospital, we find that most of the patient affected they are young patients between below 30. And we know that we are a young nation, and most of the victims, unfortunately, are from this young age group. And we know this cord injury as well as cervical injury, it end up with either complete or incomplete, but in both direction, we got to patient, they will suffer from catastrophic effect, and that will end up on burden on health institution. In United States, for example, the cost it reached like $6 billion just to take care of the 10,000 patients per year which suffer from the spinal cord injury. There is one important point before we go to our classification. I want you to understand what is the meaning of a stable spine. Stable spine is defined by White and Benjabi in 1976. And that they mentioned that spinal stability is the ability of the spine under physiological load to limit pattern of displacement so as not to damage or irritate the spinal cord and nerve root. And in addition, is to prevent incapacitating deformity or pain due to structural changes. This definition, it is very important because it will help you to define in many cases, is that going to affect my patient in neurological status? Okay, that this fracture, it can cause more pain in the future. If this fracture can cause, for example, progression in the kyphosis or in the coronal sagittal balance deformity, all this actually, it will help you to understand is this stable or not. Although the classification is something just to let you know that to create a common language between us as a medical provider, so we understand each other. When we talk by phone, we can say that this patient have, for example, class A1, and everybody he agree that this is a stable fracture, so I can relax, and you also you transfer the message very clearly. There is some investigation. It's very important in cervical and spine in general, and if you say X-ray actually is a question mark. For me, X-ray is not important as a survey in trauma. as much as it is important in planning of your surgery or for your follow-up. But CAT scan, I think, is this is the first tool to do in trauma patient, and it can give you, with high resolution, it can give you really a lot of information, and it saves time for and transportation for patient from the X-ray suite, and that's all. So the CAT scan, I will start with the CAT scan if you have a patient with trauma. Either he is especially if this patient he have the altered level of consciousness. But the MRI, it is indicated or not? Always this is a question for your colleague in other specialty or in the same your department. Shall you do MRI or not? I think if you are in doubt, just do it because MRI gives you a lot of information in the status of the spinal cord, and also you would like to see the ligaments, you would like to see the disc itself. So and also you can see now in our classification that how we are depending a lot on the MRI. MRI is considered a non-invasive procedure, and yes, it is costly, but it will help you a lot, especially if you are concerning about the stability of the patient. So in any case, you suspect discoligamentous injury, or if you have a normal CT scan but with neurological impairment, please do an MRI. If the patient have, if you would like to assess the spinal cord, and if you, or in medical legal cases like an assessment of the fracture age. Sometimes some patient, they present for you or they refer per patient to you with a fracture, but you don't know is this is a traumatic fracture or it is just secondary due to pathological fracture. So do an MRI to understand more. Also MRA is very important. It's like just to identify the vertebral artery. If you would like to see it in the MRI or alternative CT angio. This image, keep it in your mind. I would like to ask you later on about it and how to manage it and how to classify. Keep this one in your mind. Sometimes we have patient, lucky to have the patient transfer immediately after trauma. So the management plan, it becomes so, it is more different than when you have a patient like the one you are seeing in the screen. He spent months in the other hospital and then they transfer him here. And you can see the progression of his deformity in his spine. So there is, let's go to the classification. We have a lot of several classification, I can say. Before there is Allen and Harris, Anderson, but the most common is being used recently is sub-axial, or we call it SLIC classification, sub-axial cervical spine injury scale, or the AO sub-axial cervical spine injury classification. The AO's classification, it have many modification, and I'm gonna highlight today the recent one, and will take you in more detail in the AO classification. I believe it helped a lot in judgment as well, more than others. And that's why if you master one of them, like if you master the AO spine classification, I think it will help you a lot in judgment, and you can answer any question in your exam while you are comfortable. This is the sub-axial cervical spine injury classification. They have three important parts: the morphology, and the discoligamentous complex, and then the neurological status. In morphology, you can see if they grade it from 0 to 4. If there is no abnormality, they give it 0. It's only compression 1, and if it is pierced, they give it like 2, and if there is a distraction injury, it is 3, and if it is rotation or translation, that is 4. That is the worst one. In the discoligamentous complex, you can see there is, if it is intact, 0 as well, and if it is just intermediate, like isolated interspinous widening, the others things is normal, and MRI signal change only, but without any, for example, tear, obvious tear, that is 1. If it is just tear, widening is in the disc space, that means rupture of the disc space, rupture of the ligament, so that is 2. Or in case of the facet dislocation. The neurological status, if it is, they give it intact for 0 as well. Root injury, only 1. Complete cord injury, 2. Incomplete, 3. And continuous cord compression in setting of neurodeficit, that is +1. That is like a neuromodifier you added. And you can go for conservative, it is only if it is 1 to 3. And for also, it is debatable if it is 4-point either conservative or surgical, but more than 5, 5 and more, I think it is surgical. And if we spend time today in AO classification, I think it's worth it, because it gives us a lot of information about what we said before in SLIC classification, as well as most of the centers here in Saudi Arabia, they are using that one. And I think in your exam, maybe you will encounter a question in AO spine classification, either in cervical, sub-axial, or thoracolumbar as well. So they start from A to C, and also this time they add the F. The F is they related to the facet injection, and also they add the BL as well. And they add also the modifier, and the modifier starting from M1 to M4. The neurology, it is from before, from N0 to M4, and NX if if you cannot, for example, examine the patient sedated, intubated, you cannot examine him. So I'll start with the A0. A0 is the minor trauma. That's minor trauma. You see it mainly in the transverse process, in the spinous process. This is a minor trauma. You don't need to do anything. You don't need to worry about it. It happened. It can cause some pain for a period of time, but only soft color, it will be sufficient. A1 is a wedge compression, and here the diagram it show you actually how it can be mild, can be more than that. In A1, most of it is a stable fracture, but also you need to check, for example, the progression, if it is progress or not. For example, the kyphosis, if it progressed to kyphosis, or if this compression increase in size with time, that will may change your plan. But with the A1 with compression fracture, we will you treat him with the Philadelphia collar. So the A1, when we say that there is upper endplate only fracture and doesn't reach the posterior wall of the vertebral body, we call it A1. And you can see that is different when we go to A2. A2 is you have to have both endplate, the upper and the lower endplate, or both of them affected, but the posterior wall here is intact in both diagram. And that is one of the commonest one is the pincer fracture. Pincer fracture, it is a stable fracture in cervical spine, and you can't treat it with only collar. But remember that this can lead to discogenic pain in the future and all that stuff and degeneration, but as a stability, yes, it is stable. A3 fracture, it is incomplete pairs. When you have only the upper endplate is being affected and reaching to the posterior wall. Like in this picture here, you can see in this image, the upper endplate, the lower endplate is intact. Upper endplate is in fold with the posterior wall. That would differentiate it from A1. So A1, if it have the if it have the posterior wall involvement, immediately we can call it A3. And A4, if we have A2 plus posterior wall, so it is a complete pair. So when you have both endplate, here you can see both endplate is being affected and reaching to the posterior wall. So you can see that it is A4. A4 in A4. Surgery is sometimes mandatory, especially if there is persistent cord compression. And most of for you treat it, for example, with corpectomy and anterior fixation. After we finish from this one, I would like to give you some example, and we would like to practice and you will tell me how to classify this one. So be with me, so you can get out from this presentation, and you know exactly how to classify according to the new AO classification. The B1 is posterior tension band injury, and this is totally bony, and it will show physical separation through fracture bony structure only. In this one, because it is only bony, there is a high chance of fusion. So you can treat this patient with collar, hard collar, like Philadelphia collar, Aspen collar. All this is you can treat this patient with it. But if the ligament is involved, that's totally different. You can see in this one the space between the spinous process here, how it is increased, and that immediately tell you that the ligament is being affected. And you can see the MRI. In this patient, immediately you request an MRI, and that one will show you how much the ligament is being involved. Even the ligamentum flavum here, I can see is being affected in this patient. And so the complete disruption of the posterior capsuloligamentous or bony capsuligamentous structure we call it a B2. In B3, it is anterior tension band. Is more than the destruction here is an extension fashion. So that will cause anterior tension band injury. You can see this one more in a patient with a stiff spine more than others. And the physical disruption or separation of the anterior structure bony disc with tethering of the posterior element. In this one, I would like to ask you, I have come to my mind between what is the difference between the teardrop fracture, inflection or an extension? Ahmed?
أيوة دكتور.
Can you let them please answer this question? We can, any volunteer to tell me which one is worse? The teardrop fracture. Teardrop fracture is a fracture. It can happen in the anterior, in the upper endplate or part of the vertebral body. It will be separated from from the remaining part. It can be inflection or an extension. I would like to know, to take your opinion, guys, which one is worse, the one in flexion or the one in extension? Open the mic for them, let them answer this one.
طيب في عندنا إجابات عبد العزيز الموسى and عون flexion is more severe. Ali Basalama also flexion is more.
Exactly, yeah. So انت yeah, very good شباب. بالفعل flexion is worse, always associated with cord injury. In extension it can happen, but not like the flexion. Flexion is worse, and most of the time you need to do something about it. I'll continue with the here with the AO classification. C is more clear. You can see it immediately from far away that there is something wrong. Not like the we can see in B fracture. Sometimes you cannot see there is some gap. There is no gap. This is passing through the bone or not. But in C now, that's clear. There is some displacement. There is some translation between the vertebra above and vertebra below. There is malalignment. So in C, in axis displacements or translation of one vertebral body relative to another in any direction. And you can see this one, the same picture I put it before. I bring it here as well. Just to keep it in your mind, so we will discuss it later on as well. Here, we said that they put the F for the facet, so something for the facet, and sometimes we have only facet fracture, and that it have specific criteria because we know the cervical spine, the facet it play major role compared to any other structure in the any other part of the spine. For example, if you have only facet injury here in cervical spine, that means surgery immediately. Not like the others in, for example, in lumbar spine, if you have unilateral or if you have it unilateral and partially, usually is not affect the patient very much like in cervical spine. Here, if you put F1 non-displaced facet fracture, they put it is as F1, it is non-displaced with fragment less than 1 centimeter in size and less than 40% of the lateral mass. F2, it is a facet fracture with potential for instability, with fragment more than 1 centimeter and more than 40% of the lateral mass or displaced. Like the image here before, you can see is a little bit displaced and also is almost more than the 40% of the lateral mass. In F1, you don't need to do surgery, and sometimes only soft color or hard color. It depends on your judgment on the patient, compliance, and all that stuff. F2, I think you need to put for most of the at least you stabilize the patient with Philadelphia or hard color, and but in F3, the floating lateral mass. The floating lateral mass is unstable type of facet fracture, although it is unilateral, but it is also unstable, and that determine your management either with orthosis, external orthosis, or sometimes you need to go for surgical intervention. You can see this totally is being separated from the other part of the spine. F4, when you see there is subluxation or perched dislocated facet, here you can immediately put like F4, like jump facet or just perched facet. This is all our F4. And in F4, surgery is mandatory. Because most of the time, actually, in F4, you will have either neurological impairment or patient have potential to develop neurological problem. Also, they put a terminology BL, that means indicating if it is a bilateral injury, or if it is bilateral injury, you have to put a BL, and that will tell you that, okay, that is more severe. It pushes you more to go for surgical intervention. We mentioned earlier that the neurological status is a very important part in AO classification. So you start with N0 if the patient intact, N1 if it is transient neurologic deficit, N2 if patient have only radiculopathy, N3 if it is incomplete spinal cord injury, N4 if it is complete spinal cord injury, NX if it is neurological status unknown, like an intubated, sedated patient, severe, this most common with the patient post-head injury. You can put a plus if we have ongoing cord compression in setting of incomplete neurologic deficit or nerve injury. I really advise you to use always the HS score to keep it in your the patient file, and to check your patient according to this one. So not only you are taking care of the patient, now you and your colleague from for example the one who come the next day, the nurses, all of them, they have one language and all it's written here. So, and you do it, for example, in a routine fashion, and not only one time, because you know that post-trauma patients, they may pass through the spinal shock period, and that period can differentiate your management. Either this patient is complete or incomplete. If he passes the spinal shock and he starts to regain some sensation or some flickering movement, so that is incomplete, and make you more eager to do the surgery sooner than other patients. The modifier, this is the one they applied recently, and they start from M1 to M4. And the M1 is the posterior the posterior ligament complex injury without complete disruption. But you can see in the MRI, for example, you can see some edema but no actual disruption in the ligaments. M2, you can see critical disc herniation. Critical disc herniation, and that's bring the importance of the MRI in a patient with cervical spinal injury. M3, it show you the softening, and it is clear in the stiff neck, in fact, like a patient with dish or OBLL or ankylosing spondylitis. All this actually, you give them M3 immediately if they are having the feature of, for example, ankylosing spondylitis or a stiff neck. M4 in case of vertebral artery abnormality. Vertebral artery abnormality is, it can affect a lot, and it can give you a catastrophic effect if you didn't take care, or you put in your mind that this patient have this patient, he may have vertebral artery. Can you guys tell me from where, when you start think about that? For example, if the patient have more prone to have vertebral artery injury, if we have, for example, C5 transverse process as well as transverse foramina injury, or if you have in C7 transverse foramina injury. Ahmed, can you give them the mic or the answer? Let me know the answer.
Let's reformulate the question. So what is catching the vertebral artery? You mean if there is a transverse process injury?
My question is, what is the possibility if you have a C5 fracture passing through the transverse foramina, or if you have a C7 fracture passing through the transverse foramina? Which one is more to have the vertebral artery injury?
نبغى إجابات من الجونيور. So most of the answer is C5.
Okay, and that's why, because you know that, because only in 10% of population our C7 transverse foramina have vertebral artery already start from there. The others actually 90% of people actually they start in C6. Yes. So let me go with the modifier here. The modifier, look to the M1. As we mentioned, the modifier, when we have only posterior tension band injury suspected, you can see the MRI, how it can show you, how can show you actually the injury and the magnitude. For example, in the MCQ, they told you which one you will choose post-trauma, T1, T2, or with contrast, an image in MRI. This is a question for R1, R2.
We have a couple of answers that T2.
Okay, great, mashallah. Although it is very simple question, but it is very important, and sometimes you will encounter it actually in the exam. In modifier M2, you will see that in this image how the disc herniation is it can affect your management. And if I would like to ask the senior here, why the disc, if this patient, I know that he's having, for example, a little bit of translation, like subluxation or something. If you have subluxation, this patient, he doesn't have that much. But if you have a subluxation, and I did an MRI, and I found that a big disc like this one or more, what will change my, what that will happen to my approach or in management?
We have a couple of answers.
Okay.
With the MRI, we'll consider anterior approach.
Okay. If there is a disc, you mean, they will consider an anterior approach. Any other things? That's right. That's very much right. If we have a disc from the front, and it's better to tackle everything, you start from the front, because you would like to take care of this disc before you go from the back. Something else also, it will help me in my management.
There is another answer. I will avoid traction.
Exactly. So you will avoid traction in patient having a big disc. Although there is no much cases is being reported to have a disc, I mean, a neurological deterioration after traction with the disc. But also there is an evidence in like 5 to 6 cases is being reported, and that is being enough. Although it's not the big number, but this is enough to avoid any catastrophe for your patient. And modifier 3, as we said, if it is having stiff spine, and stiff spine, if we are talking about ankylosing, a dish, OBLL, or previous surgery that make your patient M3. And in M3, usually the ABC classification not applicable. The reason for that is we are not dealing with segmented spine like usual. We don't with very much mobile. No, we are talking about something very much rigid. It's like one piece, like a femur. And we have to consider everything in that one, even in our instrumentation, even in our thinking, and the biomechanic, all is different when we are talking with a stiff spine. And it can happen from minor trauma, and it is very difficult to diagnose sometimes, and associated with intraspinal hematoma in 10%. The bone quality is very bad, and also they have significant comorbidity sometimes it come with them. Here you can see in these images epidural hematoma, and this patient, he looked like ankylosed, and it's very difficult to see, but there is a fracture here as well. In the dish, you can see also the fracture line, but it is fused from the top and fused from down, and that will put a burden on that segment, in the fracture segment. Modifier 4. In 4, you can see the occlusion of the vertebral artery. And we have to know that if a patient have occlusion and you didn't treat it, or either patient will end up with, for example, a stroke as a showering impulse. It comes from there, or you don't want to injure the other part as well, the other side. If you are going, for example, from the back, and you are applying your lateral mass screw, you have to be very much careful, or you change your plan to go anterior if it's possible, just to avoid any risk of injury, and have the patient came out from the OR with significant stroke. Remember that injury are first classified by their level, and the primary injury, either C or B or A. And if you have more than one level being injured, you start with the most severe one. This is the rules in AO spine. So you can see different patient, the same patient have more than one injury. For example, C as well as B. It depend on how many level he have injury as well. For example, let's practice on this one. This one I need to have I would like to hear sounds in this example. 26 years old, involved in motor vehicle accident, and have complete spinal cord injury. I want somebody, just one volunteer, he said yes, and he start to classify this injury according to the new AO spine classification.
This is class C, fracture dislocated.
الدكتور مين معايا؟ الدكتور مين؟
فايز العلياني.
حياك الله دكتور فايز. Dr. Faiz. So we have here first of all, we have to mention, as we said here, look in the back, we said we have to mention the level first, okay? So the level, where is the level?
So this is C7T1.
Okay, great. So this is C7T1. You mentioned that this is class
Fracture
C.
dislocation. Yes.
Fracture dislocation, so this is C. Okay, there is any other things you can add, because this is the major one. You're right. So this is the most severe one. This is class C. And we mentioned here, if you have more than one level injured, you start with the most severe one, and then you go with the second, with the one to follow it. For example, here, do we have any other injury which can give us more classification, more detailed classification? So this is type C definitely. And if anybody, for example, in the phone asks you,
Facet, perched facet.
Exactly, yeah. So there is in perched facet, what we mentioned, it is F2 or F1 or F3, 4. We mentioned in the beginning. I think it is F4, huh?
Yes.
It is F4. Yeah, I agree with you. And this patient, we said, is complete spinal cord injury. So he's complete spinal cord injury. What do you think? This is what it will give him N. N0 or N1, N4. N4 is the maximum when it is complete.
Yes, like class A in Asia score.
Yeah. Class what?
Class A in Asia scoring system.
In Asia score, yeah, that's in Asia score. Yeah, exactly. Yeah. He's A. Yeah, but I mean
in 4 in the AO classification.
Exactly. Yeah, exactly. أحسنت. الله يديك العافية دكتور. هنا if you see, as you mentioned, in C7T1 we have type C fracture. Okay, that's very much clear. It is dislocated. In T1, you can see that the T1, even this one, they start mentioning these small things because it affects your management. Sometimes it's not here, sometimes it's there in this one. And that will include, that will help you in either to address this one in your surgery or not. That's why they started putting those things even with non-major fracture. They put it also in the classification. So the T1, this is an we have only anterior the upper endplate fracture. This is A1. You mentioned that he have jump facet here, F4, and maybe you don't have the images. It is bilateral, so this is BL, and is complete cord injury, spinal cord injury, so M4. All right, Ahsan Doctor, well done. I will choose this, the second one here. This patient have, this is a little bit difficult, but I want somebody to just try this one, and he may, يعني إن شاء الله تجيبوها صحيحة. 42 years old male involved in motor vehicle accident, complain of radiculopathy. Let me go through it. So this is when we go with this one, you can see this, the body itself. I cannot see there is any fracture here. Is that right? I cannot see any fracture. There is no displacement, but there is definitely something in the facet. You can see the facet here. You can see the facet here as well. So the facet here is not simple. In the same time, is not floating, and it is not pinched. So that make it like maybe F2. We said that F2 if it is like more than 40%, or it is more than 1 centimeter, or if there is a little bit of displacement. So this is like an F2. And you can, and it is only in one side, is not bilateral, is only in this side. One more thing, he have radiculopathy. Radiculopathy that will put him on which N, not N0. He's not normal. He's not normal, and he's not intact. I mean, and N2 I think is give him radiculopathy. So N2, and why he have M1 or he doesn't have M, that it depends. The M1, if you would like to do, for example, MRI or something, either M1 or M2, or that it depends on your MRI. That's right. So this one is in C5. Here they mentioned that in C5 C5 and C6, F2 and N2 and M1 here, based on this MRI. In fact, the M1 based on the MRI, you cannot tell without the MRI about the M. The N2, you can tell by your examination, the N. And this one, you can tell the fracture type, you can tell by your CT scan. So you remember this case I brought in the beginning. And here I want you to, we mentioned that it is a type C fracture. And when we say type C, we have to mention the level. So it is 5-6 fracture, 5-6 type C fracture. And we can add, it is an F4, is that right? And I have to give you some history. This patient is around 38 years old, male, referred from another hospital to us with complete tetraplegia at a level of C6. At a level of C6. So what you will, how you will treat this patient? What you need next? I want two participants to go through this. Maybe this is the last case we discussed. So you can. I want only two participants to go through me with in this page, in this case. Right. يلا أبدأ أحمد الحجي. So this is your classification as type C, is that right?
Yeah, this is right. This is type C. أول شيء معكم أحمد الحجي، مبتعث في ألمانيا Neurosurgery.
حياك
سنة
الله.
ثانية. الله يسلمك.
الله يحييك. طيب, so you go something else apart from type C. We said that it is F4 as well. Is that right?
Yes.
Okay. More things you would like to add in the classification. So it is type C, قلنا, and F4. Do you want to mention it is bilateral? This locked facet is bilateral, yes. So that will give it BL. Is that right? That is BL. And
yeah, BL.
Regarding the neurological status,
this will be probably a complete spinal injury.
So it is a complete. It's by the history and the examination. So it is M4. Okay. And do you need to request any investigation? Is this
sure? I will need an MRI.
Okay, so in this patient, MRI is mandatory. Huh? Nobody will take this patient for surgery without MRI.
Yes.
So this is the MRI. So with this MRI, you will say what type of M? Is M1, M2, M3, M4?
I think it's M4. I'm not sure.
M4 if we have stiff spine. M4 if we have stiff spine. But M4 if we have, vertebral artery. M3 if we have stiff spine. M2 if we have disc herniation. And M1 if we have ligamentous injury.
It is M1.
M1, M2 maybe, because there is some disc as well, a disc disruption in fact. There is
yes, between C5, excuse me, C5 and C6, there's disc rupture.
أحسنت Ahmed. So what is the next step, Ahmed?
I think this is a controversial case. In this patient, I will do a posterior approach first to also to open some place for the cord, then I will do anterior corbectomy and fixation.
Very good, Ahmed. طيب, أحمد الثاني, do you agree with Ahmed الحجي ولا لا?
Ahmed Hijji, you mean 360 in one sitting?
Yes. This is what I said is controversial, so I can do it either in one sitting or two sittings.
Okay, so he will go immediately for surgery, and he will start with the posterior. Ahmed.
Yes, I will start with the posterior.
ممتاز. خلاص خليك معانا أحمد. أحمد مين الثاني؟
أهلا دكتور.
هلا والله, حياك الله أحمد.
أحمد بن علي R2 المستشفى عسير المركزي.
حياك الله أحمد, الله يحييك. طيب أحمد, قل لي what you will do next.
I agree with Dr. Ahmed Al-Hajji regarding 360, but I will consider probably doing a traction.
Very good. Very good.
Before intervention.
So I like that because this is something else, and the traction, it will help sometime as in emergency situation. You will relieve some of the pressure on the spine. This is one. When you retain the spine to its normal position, you did decompression, in fact, like you are doing surgery. So it is something very important. You do the traction, and the traction itself, it can help you because this patient you referred from another hospital. That means several days. So when you do the traction, you know that your cervical spine alignment, it came back. This jump facet, it came back, and that will help you. Instead of going from the back and the front, you go from the front first, maybe, or front and back. Instead of you have to go from the back. When I need to go from the back, that it depends. If for example, the facet itself, you cannot reduce it. Unreduced facet, you need to go from the back, or if it is, for example, a chronic one, and you can see there is significant osteophyte formation and already start to fuse from the back, then you need to go and drill it and to just unlock it, and then you go from the back and from the front, then back again. Okay, شكرا لكم شباب. So you classified very well, and I think your management plan was all right, and that's what we did in this patient. But the picture here is not clear. This patient being put in traction for several days, and when he's being unlocked, then we did for him anterior fixation. And I think in this patient, he may need as well posterior as well, just to keep him, to be sure that he will not have more stress on this area. But I think because of his clinical condition, we stop at this stage, and we will see the patient with time how it will do. So we discussed the management option, and we mentioned that in most of the in a case of like fracture dislocation and jump facet and all this stuff, you need to reduce it. And the reduction you can maintain it either way, Gardner wing tongue or by hollow traction. And there is a positive thing for hollow traction if you have it, because it is MRI compatible, and not like the Gardner tongue, but the Gardner tongue is available everywhere. And I really encourage you guys, when you have any case like that, to go and put it by yourself. You will not have difficulty because you are using a lot of methyl frame in the OR and all that stuff. So the position, but also the Gardner tongue and this one, it have a little bit of different idea. Just try it and put it, because this is considered a surgical procedure as well. And here we discuss when we go for surgery as well, posterior, and sometimes you need posterior, anterior, and not only from the front, and sometimes you need to do corpectomy and to relieve the spine from the compression itself. And sometimes you need to go not only from the front and back, and that will make the patient more stabilized. This is another case, but I don't think the time is sufficient. We will leave it for another time. But quickly, maybe, if somebody would like to do surgery here, where he will fuse? From where to where, the fusion?
Personally, I will go two level.
And that's why?
Because the angulation is large and the stability is...
Okay. Anybody else? ممتاز احمد. هذه good excuse انه الانسان يروح two level، لانه in the spine you see that most of the time we go only one level، صح ولا لا؟ Only in the same level. But in this one, I agree with you. You go longer. So anybody else why he would like to go longer?
Yeah, another answer from Yasser, 3 level.
Okay, 3 levels. And why is that, Yasser?
طبعا في كذا answer انه it's a junctional area.
Okay. In this patient, because look to the spine, it is stiff, it is ankylosed spine, that's right? So yes. In ankylosed spine, you don't fuse one level, you go more, either 2, maybe 3 if it is possible, but 2 I think is acceptable. And something else, sometimes you need to really go from the back as well, not only from the front. Some people actually, they just do it from the back, but I advise in such cases to go from the front and back. That will give more stability for such patient. Well done, Shabab. طبعا, we mentioned that there is one study, it's very important. You go and read it, and I'm sure you are aware about it, regarding the static trial where they study the early versus delayed decompression of for traumatic cervical spinal cord injury. And that is really a good one to just to know the impact of how much when you interfere early can affect your patient outcome. And they conclude that decompression barrier to 24 hours after spinal cord injury can be performed safely and is associated with improved neurological outcome, and usually is 2 grade in ACS improvement at 6 months follow-up. And that is very good, as a 2 grade can help in rehabilitation of the patient very well. At the end, as I mentioned before, always they say time is money. You know, we are saying time is spine, and there is one paper is very nice, being published by Badiwala in Journal of Neurosurgery, mentioned that time is a spine, and I think we need always to consider surgical time and what to do. And I hope the classification also, it helps us to know what we do next. Not always the intervention immediately, it is the right things, but positioning your patient, stabilize your patient, hemodynamic status, that's all is considered intervention. And maybe in another time we talk about how that will impact on, in cases of spinal cord injury, how that will impact, for example, on the perfusion and preventing the secondary spinal cord injury after the direct trauma. Maybe in another lecture we have more time. Thank you very much, guys, and wish you all the best. Stay safe and stay home as well. Huh?
يعطيك العافية دكتور.
العافية. في أي سؤال قبل ما نمشي؟
Question, if we pass on it quickly. One of the question, post-anterior or posterior instrument fusion, do you use a C-collar?
In most of the cases, you don't need to put actually a C-collar, especially if you have, for example, young patient, very good bone. You put actually your screw, and you feel that really is holding very well. So that is internal bracing. What you are doing, the blade is internal bracing. So I don't need to limit the patient and cause him actually to have more cervical muscle pain in the future if I put the collar. But sometimes you have to do that, especially in osteoporotic patient or those patients who have special condition, like we said, the stiff neck and the stiff spine, ankylosed patient, all those patients actually, you may put the collar for a time to help you, and to help the fusion as well.
We have another question. How common is ankylosing spondylitis in Saudi Arabia?
Yeah, is uncommon. In fact, it is more common in another part of the world, like in the West, but here we don't have it a lot. We encounter several patients, but I don't consider them really is a good number till now. We have OPLL, but if you compare them to the people in Japan, for example, they have more numbers for sure in Asia. But to answer your question, ankylosing is uncommon in our community.
We have another question. Why would you need to go extensive in ankylosing spondylitis?
Yeah, they have usually their bone is fragile, is very weak bone, and they have intention to break. They have intention to break actually, and also their fusion is not when it formed the bone is not strong when it formed. Okay, and and as we mentioned, they are only like one piece, and that piece is being fractured in one point. So there is a lot of stress from up compared to the level to the down levels, and that's why you just increase your implanting area. That will help you, hoping that it will help you to prevent the pseudoarthrosis and failure of implant.
We have also, how long before you say the traction is not working anymore?
Really is you try. For example, if the patient, that depends on case to case. If any acute patient, he came to me with fracture dislocation and unlocked facet, I don't need to put him on traction. I will do the traction intraoperatively immediately. Third came, do the traction intraoperatively. So you don't need to do it in the back. But for example, if you are in doubt that, or you cannot have the time for surgery at this moment, for example, during this 1 or 2 days. So this is, you need to put the patient on something, on traction, just to release him. That we, as we said, it decompress the patient. Or sometime if you are not sure if this patient, if he's chronic patient, a long time, like 1 month, 3 weeks. So you are not sure that he's really fused from the back or not fused. So that will differentiate your management. So you will put him also in traction and try, you put maximum weight, the maximum you can reach. And you know the equation, I'm sure about it. You can count the head, and then you add 5 to each level. You can reach sometime 40 pound, you can reach 50 pound, it depends on the level you have. And accordingly, if it's not working, just not working, and go for your surgery.
Okay. We have a couple of questions about the traction. In case of traumatic disc herniation and breech facet, like the one before in last cases, is traction safe practically and in the exam if we encounter such case, or it is contraindicated?
Yeah, you can in your exam just say contraindicated, and said I will not do. Usually play it safe. In your beginning of your career, just play it safe, and that will keep you away from the trouble. You will not have, you don't want to have a catastrophic patient that just because you have a doubt that it could work. And I think if you say that it is a contraindicated, so that's it, is enough, and you will get the score.
In case of A1 fracture, which is treated conservatively, what is the good time for a follow-up radiologically?
Yeah.
Is X-ray enough, or should we do CT in the follow-up?
X-ray usually is enough, and most of the hospital or centers, they have, for example, their protocol. For me, for example, I use 6 weeks protocols in each X-ray, so to avoid extra radiation for patient. And this is very important things. We don't want to expose patient for extra unnecessary radiation. So 6 weeks, 3 months, and after that, 6 months, and after that, 1 year. This is the way to follow your patient if you would like to judge on progression, as well as if you would like to judge on fusion level.
معلش احنا طولنا عليك دكتور.
لا بالعكس، لا, all is yours. Go ahead, Shabab.
How to differentiate between extension and flexion teardrop?
Can you say it again?
How to differentiate between extension and flexion teardrop?
Yeah, it is sometimes difficult, but the mechanism will tell you. The mechanism, it can tell you, and also the associated injury. As we said, in extension, most of the ligaments is being injured, it is anterior. And in flexion, most of the ligaments is being injured in the back. So the MRI is very important.
This is the last question. How to manage reduction of cervical subluxation and sitting of vertebral artery injury?
How to manage? Say it again, Ahmed.
How to manage reduction of cervical subluxation in the sitting of vertebral artery injury?
Yep. In case of patient have both fracture dislocation, at the same time he have vertebral artery injury. So in this case, you have two priority now. You need to, the vertebral artery, that patient, he already have, for example, cord injury, or if he's incomplete. So maintaining the cervical spine as it is, that is very important rules. And then try to manage the vertebral artery itself by studying the course of the vertebral artery and start the patient on the management you think it is, it can help the patient. For example, if you can manage him with intervention and to put, for example, like stent or something, that's possible. Sometimes you start to hyperonize the patient, and that will reduce the risk of any thrombus. Then, if this patient, do I need to do traction for this patient? Most of them, they will have no problem if you do the correction. But as I said, if there is any risk or any doubt, no, take the patient intraoperatively and do the decompression. When I do the decompression, I have more room to manipulate and more room even for the cord itself, and then I do my reduction intraoperatively, and I stabilize him in the same time.
يعطيك العافية دكتور برناوي. Thank you very much for your time and for an important topic for us.